Hi there, so my name is Judd. I'm an anaesthetist in training, currently unemployed because I moved to New Zealand in 2 weeks. And today I'm talking to you about using virtual reality and could we use this in hard simulation training and reduce skill phase. So firstly, what is virtual reality? Everyone kind of thinks about these headsets that you use, which then transport you to into a digital world, which removes you from where you currently are in the real world. We've been developing something called Verti, which is a mobile app. The idea came from this was a way for students to be able to access virtual reality scenarios and put them under pressure of clinical scenarios without the need for headsets, and you could use their mobile phone to access different clinical scenarios, and then you would be able to look at a web-based platform and get feedback on how your students were performing. So the system works by you use a 360-degree camera. You can film kind of any scenario. You upload it onto our web-based platform, and then over the top of that, you can add in interactivity points, which the students can then interact with. You either questions or look at certain points they need to look out throughout the scenario. You then get feedback on how well the students are performing when they access the scenarios, how long they use it for, how long they're in time, and how long that kind of takes. So this is a 360-degree video of an out-of-hospital cardiac arrest, something that students won't normally see. And what we've done is overlay CGI effects over the top, which have been instructions to students on how to perform CPR, the rate, depth, and compression. This is just one of our simple methods. And then as you can see, the paramedics can move it around. So what we it was all a great tool, and everyone thought it was a quite a gimmick. Does it actually work? Does it do anything? Do students find it useful? So we did a randomised control trial, managed to recruit 24 second-year medical students. Half of them were randomised to be taught just a standard hospital life support course and the use of an AED. And the intervention group had the same standard course and taught with the other students, and then were given access to the virtual reality app, the HLS scenario, which taught them the same things they were taught in the course. After 48 hours, students then underwent the test simulation, so they walked into the room, there was an American airways and cardiac arrest. We wanted them to manage it as they'd been taught. Through the scenario, there were kind of 8 key clinical decisions that we wanted them to make, so they scored a score out of 8, and depending on how many of those they did. We also measured how long it took them to perform each one of those tasks. After the scenario, we then asked the students how useful that they found their teaching method, and whether they felt that impacted on how well they performed, how their stress levels were through the simulation, whether they felt the stress had a factor in how they performed. We then went on and conducted a repeat assessment 3 weeks afterwards, where students who had access to the app continued to be able to use it, whereas the other students, as normally with a standard course, had no further follow-up training. So we look at how many correct clinical decisions were made during the scenario, how long it took to get to those decisions, confidence in students on how confident they felt to perform HLS, the steps of it, and how confident they felt to perform in real life, and then looking at stress levels and how that was impacted. This is a bit of a rubbish graph, and I should take it out. But in summary, what it shows is that the intervention group did more correct clinical decisions than the control group in the first simulation, and that actually was pretty even between the groups in the follow-up simulation after 3 weeks. Looking at time to making key clinical decisions, students with the virtual reality app came to each clinical decision quicker than those that didn't have access to the app. And then looking at performance, so students that had access to the virtual reality app felt more confident to perform HLS, the steps of it, and more confident to actually perform it in real life. They enjoyed the teaching method more. They felt that the teaching method reduced the level of stress they had through their test simulation, and that the stress was then less of an impact on their performance. Then looking at the follow-up assessment, both groups improved, and in the majority of the time, again, the students with access to the virtual reality app were faster than they're making those key clinical decisions, apart from when calling for help. Actually, the non-VR group, for some reason, did that quicker the second time round. Looking at the scores after their second assessment, students who had access to the app felt their confidence to perform HLS had dropped less than those that didn't have access to the app. However, with those that did have access to the virtual reality app felt that the second simulation was more stressful. They felt they'd lost more knowledge in their initial training, which wasn't what was seen, and that they felt that stress was more impacting more their performance in the second simulation than the first. We wonder here whether we moved our those that had access to the virtual reality app, instead of being unconsciously incompetent, we moved them up the ladder to consciously incompetent, and that may explain those results. There are a number of limitations. The control group weren't given any other manuals or handouts, so they couldn't have any follow-up learning through after the 3 weeks or after they had their initial course. It's a pilot study, so it is underpowered. And unfortunately, the follow-up simulation was limited to 3 weeks due to curriculum constraints. Ideally, we would run it to 3 to 6 months, as we know that's likely when you see more likely to see skill fade, and we may have seen more of a difference then in our results. So most of the clinicians kind of suggested that this blending teaching course of using virtual reality could improve student performance, and that improved performance may be maintained longer term. That with access to virtual reality and putting these students in 360 real-life videos means that they may then be less stressed when faced with simulation testing, which could then be accounting for improving their performance. So indicates that remotely accessible VR scenarios may enhance learning of resuscitation skills and reduce skill fade. Future applications are things that we're looking at the moment. So we talked about resuscitation courses, a student developing a virtual reality OSCE as a revision tool, using it for patient experience. We're doing a project with Tottenham Hospital for their intensive care patients about having a tour around their ICUs in virtual reality prior to admission for elective patients. And also using it for lectures. Thank you very much.